Bismillahirrahmanirrahim. Our case today very interesting. 18-month-old girl, known case of Down syndrome, status post AV canal repair. There is median sternotomy scar. After 24 hours from surgery, nursing staff reported to Dr. Sharif. On call doctor at the time reported to him the patient developed tachypnea, so respiratory rate reached to 60 cycle per minute tachycardia, and also there is desaturation up to 82% on FiO2 oxygen requirement 40%. So Dr. Sharif came immediately for evaluation and assessment of the patients by history, clinical examination, impression. Then he was requested for laboratory or biochemical investigations after clinical assessment and radiological assessment. So Dr. Sharif started to assess the baby. Baby was tachypnic, desaturated up to 82% on FiO2 oxygen requirement 40%, and by clinical assessment decreased breath sound on the right hemisthorax more than the left side, and also there is dullness to percussion. So there is 2D, decreased breath sound on the right hemisthorax, and there is dullness to percussion. So from history and the clinical examination, patient with Down syndrome, AV canal, status post surgery, and the baby start to be symptomatic, tachypnic, distressed, desaturated. From the history, clinical examination, the impression and assessment evaluation, there is pleural collection. There is pleural collection, either transudate or exudate or chylothorax. But the most probably it will be chylothorax. Why chylothorax? From history, Down syndrome, still supposed to AV canal, and also surgery. So there is thoracic duct injury, thoracic duct damage or injury. This suggests this patient having chylothorax, and also there is 2D, decreased breath sound and dullness to percussion. What about the plan of care? So plan of care, remove chylous fluid or milk fluid and find out the cause. Thoracocentesis, it will give you clue about what? This is transudate, it will be clear. Exudate, it will be cloudy or pus due to high protein, or lymphatics, it will be milky material. And also you have to find out the cause. So after clinical assessment, Dr. Sharif requested for laboratory investigation or biochemical investigation and radiological study. So what does X-ray show? X-ray show decreased aeration in the right hemisthorax and also obliteration of costophrenic angle or loss of the right costophrenic angle, and no evidence of tracheal deviation. If this the only problem in the patient, what is the most likely diagnosis? The most likely diagnosis, chylothorax. Chylothorax, it will be isolated or associated. Isolated, congenital idiopathic chylothorax, or associated will be syndromic, baby dysmorphic, either chromosomal or congenital abnormalities or congenital infection. If the patient asymptomatic, what should you do? Patient asymptomatic. If asymptomatic, but our case is symptomatic, no other concern, just to only observe or conservative treatment and repeat X-ray is essential. Because idiopathic chylothorax, it will resolve spontaneously, while chylothorax it will increase with increasing the feeding. If the baby asymptomatic, conservative treatment. This means you have to observe the patient vitally and hemodynamically, and repeat X-ray are essential. If the baby symptomatic, what are going to do? So this patient symptomatic like respiratory stress or oxygen requirement increase, so we need respiratory support, oxygenation and ventilation, and you have to drain the pleural collection or the pleural fluid or the chylothorax. What about the investigation? Dr. Sharif, he will requested, it depends on the general condition of the patient and depend on the fluid drain. So if the baby will or asymptomatic, just to only baseline investigation, hematological and biochemical, it will may be indicated. If the patient unwell or symptomatic, For sure, you have to look for the cause. You have to request for chromosomal analysis, and viral study may be also indicated. If fluid drained, so you have to send for A, analysis, B for biochemical, and C for cytology or culture. If there is chylothorax, so it will be high lymphatic or lymphocyte count, indicate chylothorax, and Sudan 3 it will be positive, and BH it will be 7.4 to 7.8, high triglyceride more than 110 milligram per deciliter, and cholesterol it will be less than 200 milligram per deciliter. So in summary, the key points. What are the causes of chylothorax? Chylothorax, this means milky material. So what are the causes of chylothorax? The most common cause, congenital idiopathic chylothorax, and also resulting from what? Collection of lymphatic fluid in the pleural space, due to what, or secondary to what? To leakage from thoracic duct or its main tributaries. What are common syndrome associated with chylothorax? Turner syndrome, trisomy Down syndrome, and Noonan. How to diagnose chylothorax? Clinically, laboratory, or biochemically and radiologically. Clinically, there is decreased breath sound and dullness to percussion and decreased tactile firmitas. It will be in older child. Laboratory, it will be increased lymphocytes in the drain and the positive Sudan 3 and increase triglyceride. X-ray or radiological treatment, it will be decrease aeration, like in our case decrease aeration in the right hemithorax, and also it will be obliteration of costophrenic angle or loss of costophrenic angle and deviation of the trachea if there is large effusion. Our case also, it will see there is median sternotomy clips or stitch, median sternotomy clips. There is clinical diagnosis, laboratory diagnosis, and radiological diagnosis. How to manage chylothorax? By 3 lines of treatment. So how to treat? You have to remove the chylothorax or the fluid collections, and you have to find the cause. So the line of treatment, the first line, general measure. 2D, you have dietitian modifications and decompression or thoracosynthesis. Medical treatment or pharmacological treatment, it will be octreotide. Surgical treatment, it will be thoracic duct ligation or closure. So general measure, the first D, dietitian modification. So you have to keep the baby NPO, start the TBN, restrict fat, minimal amount of very long chain fatty acid, and you have to give or to use MST oil, medium chain triglyceride. Why medium chain triglyceride? It will be early or easily absorbed, and it with absorbed through also, it will be absorbed through the portal circulation, bypass the lymphatic circulation or lymph vessel. The third reason to use MCT oil, also it will give adequate caloric requirement. The second D, it will be decompression or thoracosynthesis. So pleural catheter drain just to keep the lung expand against the chest wall and mediastinum. So this is the first line of treatment. To call it conservative treatment, it's 2D, dietitian modification and decompression or thoracosynthesis. Medical treatment for chylothorax or pharmacological treatment, octreotide or IV octreotide. It will act direct and indirect. Direct through somatostatin receptor, it will be vascular somatostatin receptor, so it will decrease the lymph flow and lymphatic excretion. Indirect, through decreased GI flow, for sure it will decrease the lymphatic flow. Surgical treatment, it will be thoracic duct ligation or closure. So the treatment, it will be general, So dietitian modifications and decompression thoracentesis, medical pharmacological treatment, octreotide decrease the lymph flow, surgical treatment it will be thoracic duct ligation or thoracic duct closure. شكرا، سلام عليكم.